Hello and welcome to the Reducing Hospital Admissions Learning and Action Network for this month. I am Sarah Eve Schaefer, the facilitator for the ESRD National Coordinating Center. We have 3 networks presenting today, so I will just start with a few housekeeping slides and move right into presentations. These calls typically take about 40 minutes now that we have a condensed time format. So the call is being recorded. The NCC will post this to our YouTube page. And so if you're looking for the recording after this event, please go there. The NCC will also send out the slide deck to the ESRD networks to distribute in their network service areas. Everybody is muted upon joining the call. Panelists have been promoted and so can unmute themselves when it's time to speak. If you have comments or questions, we welcome that, but please do use the chat feature. That is the easiest way for us to manage this. And again, we will post the deck to the NCC's website, and we'll also share that out with the ESRD networks. So we just like to frame our Learning and Action Network call today. So please listen and share approaches, comments, questions, experiences via chat. We do like this when it's interactive. As you listen to presenters today, identify how the information they are sharing could be implemented at your facility or in your network. Try to take at least one idea from today's LAN back to your facility and commit to sharing this with your colleagues. Really, the point of these is to learn and move into action as they are titled. So we're going to just check and see if chat is working. So if you hold your phone over that QR code, you will see all of the change packages that the ESRD NCC produces. So testing out chat, please go over to chat and make sure it's toggled to everyone and let us know if you've previously used the change packages at your facility. While I give everyone a chance to click in there and answer that question, I will say that every year the NCC updates the change packages. We are completing our change package revisions for this year. We interviewed top 10 performers across the country. Great. I'm seeing some yeses there. Also lets me know that chat is working. So please, as you have questions or comments for the presenters today, please pop those in chat. And with that, we will get started with Amy Carper from Network 7. Amy, you ready?
I sure am, Sarah Eve. Thanks. So I apologize for not being able to have the facility representative on the call today, but I did interview her on last week and got some of the things that they're implementing at their facility, excuse me, and have gotten those all pulled together for you guys today. I did speak with Dawn over at the U.S. Renal Care Facility in Lehigh Acres, and that is in Lehigh, Florida. Next slide. The Network 7 began working with Lehigh Acres in a focus group targeted to hospitalization use or unplanned hospitalization use in October of 2023. The network and the facility are specifically focusing on their emergency department use. The time of inclusion at when we started the PDSA cycle, the facility had a rate of 4.26 visits per 100 patient months. I always explain that. So if 100 patients treated for 1 full month, CMS would pretty much categorize 4.26, almost 4.25 patients got up and used some sort of emergency department visit, which is higher than the national average and the rate for Network 7. 4 months later, their current rate using the January 2024 NCC data has decreased by just about half. So 2.25 visits per 100 patient months. This made them a high performer for us, and we wanted to know what they were doing. So next slide. Began talking to the facility, and this hopefully is something that all of you have seen, and if not, came up on your phone when you use that QR code. It is the change package for reducing hospitalizations, and part of what Network 7 has been working with all focus facilities to do is really go back to those best performing facilities and adopt or implement some of the things that they were doing well. Interestingly, for the facility, they had a hard time identifying which primary driver they wanted to work on first. And what they decided to do is really use one secondary driver from each primary driver to start and see if that led them in a better direction. And really sort of fleshed itself out at this point in time, even with the reduction in emergency department use. They hadn't identified which of those four. They kind of like touching in on a little bit of each. So for the primary driver one, Don explained that the facility is really trying hard to keep the focus on patients and family and creating a culture that contributes to low hospitalization. By doing that, what she specifically means is that after they were included in the hospitalizations endeavor with the network or quality improvement activity, they really started going to each patient individually and educating that patient on signs and symptoms of illness or injury or distress and what to do when different things happen. The facility has always kept in mind, you know, if you're bleeding, if you've hit your head, if it's something like that, please do not stop. Just go to the hospital. But if you're having some symptoms or rapid heart rate or something that is different for you, please call the facility first and we'll help you identify maybe where to go next or where to go with your care. And if we can get you in here and have you assessed by the nurse, or if we can get you to your primary care physician, we would like to keep you out of the hospital. Many people at this particular unit, and I would say across the country, are really used to just sort of fast tracking themselves to the hospital. Part of what they really wanted to identify for themselves is under primary driver two, tracking hospitalizations and related measures. Many facilities have lumped together mistreatments. And that's great when you're trying to see how many patients are coming and if they're staying their entire treatment, and if not, why they're not coming. But what it doesn't do is really drill down on the specific reasons that patients have missed related to hospital use. And so they've begun using a tracker that the network has provided and is available on our website for hospitalizations. The fun part of that tracker is that it also allows facilities to individualize the columns and the reasons or what they want to track. It also provides an opportunity for the facility to set a goal that they think is realistic. So for instance, if I ask the facility at the beginning of the year, what is your ideal rate of emergency department use? They might say, you know what, once every other month, maybe one of our patients needs to go. So a 0.5 hospital rate instead of a 2.25, which is where they're at now. We know, and I always say Medicare knows, that a zero rate in all areas of hospitalization isn't necessarily attainable or realistic. So what can we do, and what is your facility working on? They're also implementing a process to avoid hospitals and readmissions by I'll say 3A, proactive steps to prevent hospitalizations. Again, they're meeting with facility patients individually, which ties right into number 4, where the staff are individually talking to patients about playing an active role in their care, reaching out to the facility if they're not feeling well, reaching out to their primary care physician if there is something going on, and not just immediately taking themselves to the hospital unless it's in one of those, I'll say, red light categories. So, so again, what can patients do to really work with the medical professionals that they know to try to stay out of the hospital? Next slide. So again, they've combined all of the different drivers and really started to put in place a process that meets with not only all existing patients. What she described is that they have changed their monthly education. Again, we all have lots of things going on, and at this facility, monthly education usually is something around an area of care. So for instance, access management, or what to do in case of an emergency at the clinic. And those handouts usually go out, I'll say, to all patients, and patients have the opportunity to ask questions. With hospitalizations, they're proactively meeting with all patients who've been there for a long time to educate them individually on anything, and with the results that they're finding and the outcomes that they're having, they're really starting to adopt some different educational processes for some of the other educational topics that they're using. They've also learned, for example, that 3 patients at this clinic routinely get an extra treatment each and every week, and that has prevented them from going either to the emergency room or the hospital. Next slide. Some mitigation strategies that the facility is using, again, is to get the patients to call the clinic for assistance. When I spoke with Dawn, she also reinforced that with new patients who've started coming to the clinic, they're really meeting with them really upfront before habits or different things are identified, and making themselves an available resource for patients. That the clinic does have some extended hours, and that these patients can certainly call at any point in time if there's something going on, and again, try to really avoid use of the hospital if possible. The facility is using that hospitalization zone tool that educates patients on whether or not um, they need to go directly to the hospital. Again, that red zone, something that's more important, but not um, an emergency, to get a hold of someone at the clinic. And then again, something that maybe the patient wants to write down or remember to bring up upon their next treatment, which is more of a green zone. And they've modified some of those sit down and round questions. Sit down and round is an intervention that Network 7 has been using to increase communications with patients after they've gotten out of the hospital. They sort of turned this up and have started asking patients questions before they go to the hospital about what might make you feel like you need to go, or if you experience this or that, how could we help you without you going to the hospital? So rather than being reactive and asking patients what their experience was, they're trying to be proactive and really set a plan in place for if patients do experience symptoms. And something interesting that Dawn also shared with me was that they've gotten some mitigation strategies for staff. The example that she used is that when meeting with the patients who might have more difficulty struggling with their fluid intake, and maybe keeping down the dry weight in between treatments, they've identified some culturally sensitive or um, culturally prominent foods, like soup, or things that I'll say a lot of the population has been enjoying, that wasn't being directly correlated to their fluid intake. And so they've changed their education, but it's really through meeting with the patients proactively, individually, that this has happened. It's not that their phosphorus is off, or the dietitian hasn't been doing their job. It's just when they directly are relating it to um, your reason to go to the emergency room, they've come up with some different information than they have, and that is intended to be used and drilled out by all disciplines. So they've involved all the staff in the process of meeting with these patients individually and talking to them about hospital use and how to really try to avoid that. So next slide. I think that's all that I have, and it's what I have in my notes from speaking with her. They've done a great job in reducing their rates, and if anyone has any questions, I can try to be of assistance.
Hi, Amy. Just one question there, and that comes from an attendee asking if the hospitalization tool can be shared.
Oh,
Hospitalization zone tool.
absolutely. Yeah, I
Okay.
can definitely make available and on our website are both the zone tool, where again it's sort of a triage on if you need to go immediately to the hospital, if it's more of a moderate need, or if it can wait until your next treatment, and the hospitalization log.
Great. So I can share those then with the ESRD networks following the call with the other post-event materials.
Absolutely. Thank you so much.
Sure. And then spirit of time, we're going to move forward with Network 8. Sheila and Heidi.
Thanks, Sarah Eve. I'm going to introduce our speaker today, Heidi Ferguson, who is the Director of Dialysis at the University of Mississippi Medical Center. Heidi came to us by way of Texas. She's been here about 5 years. She has 2 programs. One's a pediatric program that is housed within the academic medical center, and one is an outpatient program with about 150 patients, a home and in-center program that is housed in the Jackson Medical Mall, which is an inner city area with tons of challenges. And I will post a link to the Medical Mall story in the chat a little bit later. It's a very interesting story about how the Medical Mall came to be, using empty retail space to meet medical needs of disadvantaged patients in Jackson, Mississippi. But Heidi has been a great partner to the network and a joy to work with. And Heidi, I appreciate you taking the time to talk to us today. So I'm going to turn it over to you.
Thank you, Sheila. Can you hear me?
Yep, you sound good.
All right, thank you. I was curious what her introduction would be like. She's the best. So we are an academic medical center here at university. As Sheila said, we do serve a very underprivileged population. And so what we started out to do is we had a fellow who was graduating and needed a end project to take on. So we said, okay, here is your project to take on. And so next slide, what we did is Dr. Schwartz, he actually came up with this huge poster that I put up here, and it actually sits in the wall there of the renal area of the hospital. And so what we did is we tasked him with finding out, okay, where are our hospitalizations coming from? Where is the biggest amount, and where can we make the biggest difference? And so in his analysis, what he did was he found that when we're speaking strictly of in-center, out of the 142 admissions that we had during his review period, 80 of them were dialysis related admissions. So over 50% of our dialysis patients admitted were due specifically for dialysis related reasons. And upon reviewing, so he actually went in, reviewed their hospitalization, reviewed their pathway, everything about it. And he felt like almost 60% of those were preventable. So those are the ones that we decided to tackle. Next slide. One of the 2 controllables we felt like we could work on were access interventions and missed treatments. So what we were finding is that when our patients were coming into us and their access was clotted, catheters didn't work, we would send them to the hospital because we also do not have any type of access center. They actually have to go to the hospital and we have to slide them into interventional radiology. So what we were finding is that when they go to the hospital, they get labs drawn, their potassium was high, or some of their labs were off to the point where they would have to be hospitalized overnight just so they could get that potassium down, just so they can get them to the point where they can go on the table. And so that was one area where we really thought we could make a difference and avoid hospitalizations for that. And the other area we thought we could really do some damage on is the mistreatments. Next slide. So what we started doing as far as access interventions go is we're getting labs prior to going to the hospital. So we have set up a routine now. It's a standard. The patient comes in, we have a protocol that says go ahead and get this, and this lab. We get it to the doctor. The doctor says, okay, look, let's control this potassium before we send you to the hospital, because as soon as you get there, they're going to keep you overnight. They're not going to work on your access. We're going to take care of this outpatient with medications. And so that when you do go to the hospital, boom, you can go right into interventional radiology and not take up a bed, because the issue is also bed space in such a tight hospital. So we collaborated with the IR and with lab as well, so as that we could streamline this process, because our patients also don't have the means to go from one place to another. We need to have almost a one-stop shopping because they don't have transportation. So we really worked hard on getting the labs taken, getting those addressed. If everything looks good, okay, we coordinated transportation to get them over to IR at a time that they're not sitting in IR for 8 hours and just give up and leave. So that was a big deal. That was amongst the nephrologists, radiologists. They really got together and just came up with a plan that works. Next slide. And I know it's not leaps and bounds, but from 22 to 23, when we started implementing that program, we were able to decrease patients requiring hospitalization strictly due to accesses. That was 8 patients over the year. I know it's not a lot, but I do believe in baby steps. And if you just keep taking baby steps, eventually it pays off. So we were able to reduce in that area. And it's a plan that is actually sustaining us. So not only was it established, but I think it's something that will easily be carried on in the future. Next slide. Okay, and this is everybody's problem to bear. So mistreatments, big issue for us. Again, we live in an area where many of our patients do not drive. They rely on public transportation. This area has trouble funding public transportation. So it was something, I mean, we had everything from, we had patients who missed 12 treatments a month. And you would think, why are they still with us? But they were able to, they figured out how to hold out. So we actually worked with our interdisciplinary team. We worked with Network 8 for some resolutions. We do utilize well checks, and we found that our patients really don't like the police showing up. It is something, they don't want them coming to their job. They don't want them coming to their apartment. And so if they have to come here once a week just to avoid the police coming, then okay, I'll take that too. Patients who would frequently miss Saturdays, we tried looking for schedules that better suited them. You know, we very much were, everybody likes to put that patient who frequently misses on TTS2, and I know it does a lot for productivity. And so we tell the patients, I can try you on a different schedule, but if you start missing, I cannot keep you here, because, and then, I mean, I would invite the patient to look at my productivity. I would show them the behind the scenes. I would show them, and it's not about them, it's about the health of the clinic, because if I can't show productivity, I can't stay open. We incentivize patients. You know, we do this bi-weekly drawing, and we make a really big deal out of this. We do for every 2 weeks, a patient who showed up every treatment and did not cut their treatment, they'd get to go from this little prize bag, little prize cart that we push around. And we also do the most improved. And so I have a lot of patients who come up to me and say things like, Miss Heidi, I didn't miss. Can my name go in? Can my name go in? So for some reason, these small little $10 or $15 prizes has been something they've really been looking forward to. We also do what we have here. We have an incremental program here for those patients who have still quite a bit of renal residual function. We only do 2-day-a-week dialysis for those patients. It is a nice alternative because we find that people who miss 1 day a week and they do just fine, labs are great. Okay, well, you know what? Maybe they can only go on 2 days a week. We have one physician here who oversees the program. And as long as that patient can still maintain, we want to leave them on as little dialysis as possible, just because it's better for their lifestyle. Again, we do slow but steady thinking, and eventually we get somewhere. Next slide. So in 2022, we had 1,037 missed treatments. In 2023, we were able to reduce that by 8%. Again, you're not going to change people overnight. It's a slow but steady thinking, and it has paid off in the end. In 2019, there was a 9.1 mistreatment rate. And I just worked the numbers for January. We are actually down to 4.06. We had our lowest number of mistreatment rates of only 58. Some people may think that's still a whole lot, but when you start out in the 150s and 170 mistreatments a month, this is huge for us. And we make sure the patient knows we recognize when they're not here. We celebrate when they do come, and sometimes it works and sometimes you still have those that will not. So that's our just slow but steady thinking. Any questions?
Well, that was excellent, Heidi. Thank you, Sheila, for popping in some information in there. Just one quick question, and that was,
Yeah.
just lost it, about how could you do biweekly drawings without incentivizing treatment? We've been told we cannot incentivize treatment.
Well, what we're doing is we're celebrating the wins. We are celebrating those who are doing, who are coming to each treat, because every patient we have here has one challenge or the other. Many of our patients, they are the sole caregiver for their parents, their adult children. Many of these patients, it is a struggle just to physically get here, let alone stay the whole time. So we are celebrating the wins. We are celebrating the patient being here. We are celebrating them being here.
Great, excellent. That seems to be resonating with people. Everyone is still welcome to pop in comments or questions, but we are going to move to Network 9. Katie, if you'd like to get it started.
Thanks, Sarah. So my name is Katie Chorba, and I am the Network 9 hospitalization lead. We can go to the next slide. And today we are going to talk about a facility that is doing some great incentives to get patient engagement, as the speaker before, to celebrate some of the wins. So Network 9 is compiled of 3 states, Indiana, Kentucky, and Ohio. And today, we can go to the next slide. We're going to talk about DCI Danville. They are located in Kentucky. They are an in-center hemodialysis unit that have a census of about 52, and they're open 6 days a week. And I'm going to let Linnea and Rebecca speak about all this fantastic work that they're doing within their facility. Ladies, you guys can take it over.
Thank you. Yeah, so we we're focusing with our
And yeah, I think did we lose your audio? Katie, can you hear them?
I cannot.
Okay, neither can I. Just making sure.
She just said, "Oh no."
I know.
Maybe they're-
You're muted. We're not muted from my screen. You should be able to talk now.
now.
Hello?
We can hear you now. Oh, we could.
I know Lainey and Rebecca are in the same room, so.
Yeah.
I don't see anything from my end.
I don't either. Oh, hold on.
Can you hear us?
Yes, we
Yes.
can.
Oh my goodness. Yeah, this is Rebecca. I
You
don't know
guys are
what-
good now.
So you heard us a minute ago?
Yeah.
Oh, they keep cutting out, it looks like.
Oh. Rebecca, Linnea? It seems like they might be cutting in and out.
Okay.
I'm not sure. Katie, if you can speak to some
Yeah,
of this.
I can speak to some
Excellent.
of it. Absolutely. So DCI Danville wanted to focus on reducing some of their hospitalizations and their readmissions and ER visits. So they wanted to think about what they wanted to focus on. And so there are higher rates of fluid overload and access infections. And you can go to the next slide. So they had a plan to reduce these hospitalizations based on these two things. And they wanted to get patient engagement and involvement. So they needed to think of something that was going to be very creative and a reward system for the patients and some positive reinforcement. So the facility decided you can go on to the next step. Okay, so the facility wanted to create these cards with a catchy slogan. Each card would have 12 squares that would have 12 opportunities for the patients to monitor their fluid or their access care. If the patient has a 2.7 kilo or less weight gain between treatments, or if the patient washes their access when coming into treatment, they would be able to mark off one of their squares. So the staff will sign them and date the cards when the patient accomplishes each of these. Once the cards is full, that all 12 slots have been signed and dated, they will go to the manager and the patient will receive a treat bag. The patient will get another card to fill out. So they were able to increase patient engagement and decrease hospitalizations and infections for fluid overload. We can go to the next slide. And here's one of their really great, they have a really nice slogan. So here's a tip, just take a sip and you'll avoid a hospital trip. And then on the back of the card, that's where the technicians or the nurses can sign each time that they have that. And then on the next slide, you'll see their access slogan. Wash your access to remove the grime and it will save your lifeline. And so every time the patient comes in and as soon as they walk into the treatment area, they're washing their access, one of the staff members will sign and date it. And we can go to the next slide. So their results for option period 2 for our work is there had 2 hospitalizations so far this year. They have had no readmissions and they have had only 1 emergency room visit. And then they had some patient, if you go to the next slide, so they had some patient experiences. And I was talking to Rebecca, I believe, the other day, and she was telling me that the one patient gets so excited, and they were trying to ask him, like, you know, what makes you and motivates you? He's like, well, I give the bags to my granddaughter. She loves the candy. So he like makes sure he gets all of his cards signed up so that way he can give his bags of candy to his granddaughter. Does anybody have any questions? And it looks like Linnea and Rebecca can answer some of those in the chat as well, if you have some that I might not have the answer to.
Not hearing anything, I will pause and move forward the NCC portion, but if there is anything that you have for network 7, 8, or 9 or the presenters today, please feel free to put that in chat. So we do ask you to give us a like and a follow on the NCC social media. We're on Facebook, Instagram, X, and YouTube, which is where the presentation recording will live following today. And then just one last plug here for the change packages. If you didn't have a chance to open that QR code and access the change packages, it is here again. Again, the NCC is in process of revising these and getting a new batch out to the community. And then please, when this call is over, there is a post-event survey. If you can just take that, it helps us ensure that these calls are meeting the needs of the attendees. That is it for today. Everyone had a great presentation. Thank you to all of the presenters for taking the time today. And please do have a great day. Thank you.